Hello friends, I am Dr. Shah Hussain Biradar, Khizar Super Speciality Hospital, Vijaypur. My dear friends, I would like to discuss today the topic the diagnosis of chest pain in the OPD. This topic is intended to educate general practitioners to diagnose the chest pain in their OPD with limited resources in a shortest time. I hope my effort will help the general practitioners. Before I begin the topic, I would like to tell you that a famous quote, if you want to gather the honey, don't kick the bees. I would like to modify this quote in a professional way. If you want to gather the wealth, don't lose the patient. Patient is very important. It may be single patient for you, but he is worth of thousands. If you save one life as if you saved whole humanity, don't lose the patient because of the misdiagnosis. Be the perfect to diagnose the chest pain. You can ignore the any pain, but do not ignore the chest pain. It could be serious life-threatening condition you are dealing with. We begin the topic diagnosis of chest pain. My dear friends, pain is the only symptoms brings patient to a doctor. If there was no pain in the world, nobody would sought the help of doctors. So we should be thankful to the symptom of pain. So patient seeks help of a medical practitioner nearest to him. During the pain, he doesn't see your degree, your qualification, your ability, your knowledge. All he wants is an immediate relief. He bothers little about your infrastructure, your qualification, your knowledge. My intention to improve your clinical efficacy of diagnosis. Hope my little effort will help you in the diagnosis of chest pain in your OPDs with limited resources, because as a general practitioners, all you have an BP instrument, pulse oximeter, thermometer, and at the most ECG instrument. My dear friends, I would like to tell you that 90% of the chest pain can be diagnosed on a well taken history and well clinical examination done. That is enough to diagnose the 90% of the chest pain. You can easily rule out 90% of the chest pain. You don't require higher or sophisticated investigation everywhere and any time and every time. My dear friends, we begin the topic of diagnosis of chest pain. The chest pain we classified into two types. One is pain caused by the cardiopulmonary diseases. Second, non-cardiopulmonary diseases. There is little correlation between the severity of the chest pain and the seriousness of the cause. The range of the disorders that cause discomfort are potentially serious. Sometimes pain may be so serious, the cause may be minor, non-life threatening. Sometimes the pain may be mild to moderate, the disease may be life threatening. So please do not ignore the symptoms and signs of the patient. Be careful to take the history, examine him properly. Do not ignore the patient, otherwise you'll land up in serious liabilities. We deal with first potential serious causes of chest pain. The differential diagnosis of the chest pain. It is useful to characterize the chest pain as new, acute, and ongoing, or recurrent, episodic, and persistent. Example, for hours or days at a time. First cause I would like to rule out is myocardial ischemia or angina pectoris. My dear friends, what is myocardial ischemia? Myocardial ischemia is the condition where the coronary artery blood supply and demand hampers that leads to ischemia. Ischemia leads to pain. Before I would like to go into detail, first I would like to explain about the normal anatomy of the coronary arteries. My dear friends, this is heart, this is arch of aorta, this is right coronary artery and its branches, this is left main coronary artery, this again divided into its branches, this is left anterior descending artery. The ischemic pain is substernal pressure, squeezing type, constriction with radiation, often radiate to the left. If the anterior wall is involved or lateral wall of the heart is involved, the pain may radiate into left arm. If the inferior wall or posterior wall involved, then the pain may radiate into right arm or epigastric region, back. Usually, or in stable angina pectoris, the pain occurs on exertion, especially after heavy meals or with emotional arousal. Characteristically, it is relieved by rest and nitroglycerin. This is the classical feature of angina pectoris. Now next, acute myocardial infarction or unstable angina. My dear friends, acute myocardial infarction occurs when coronary artery occlusion is total. 100% coronary artery is occluded. The myocardium is totally lack of blood supply, that suffers infarction. This is very serious and life-threatening situation. Angina, or this is also called as angina, unstable angina, similar to angina, but it is more severe in nature, of longer duration, more than 30 minutes it lasts, not immediately relieved by rest or sublingual nitroglycerin. There may be clinical features, clinical signs S3 or S4 gallop may or may not be present. Even if present, you may not be able to pick it up. Don't go on the heart sounds. Be serious about the clinical features, signs and symptoms. My dear friends, this is the left coronary artery. Here it is the lesion. Then the pain may radiate to left side of the chest, left arm, back, associated with palpitation, perspiration, nausea, vomiting, syncope. Sometimes due to ventricular arrhythmias, patient may collapse and die suddenly. I'll tell you how the occlusion takes place. See, this is right coronary artery. This is internal structure of the right coronary artery. See, there is an atherosclerotic obstruction has developed. The internal diameter is almost reduced to 10%. What will happen if the internal diameter is reduced? The flow of blood is reduced significantly. The myocardium next to this lesion suffers imbalance between the oxygen demand and supply, hence leads to ischemia. That causes chest pain. It is an alarming symptoms. We can diagnose it easily in the clinical setting with a limited resources. A simple ECG enough to diagnose. You don't need to be expert in the ECG. Even if you are not able to read the ECG, you can get it reported online within couple of minutes. Next life-threatening condition is pulmonary embolism. What is pulmonary embolism? My dear friends, the total occlusion of or main or branches of pulmonary artery that leads to infarction of the lung, that is called as pulmonary embolism. You must have high index of suspicion. Patients who present with pain may be substernal, lateral, pleuritic in nature and associated with hemoptysis, tachycardia and hypoxemia. Patients who have become all of sudden breathless, you should have a high index of suspicion, especially in patients who are bedridden, prolonged leg immobilization due to orthopedic causes like fracture, abdominal surgeries, or patients who have malignancies. They have potential to develop pulmonary embolism. Dear friends, this can be diagnosed in clinical settings with limited resources. A pulse oximeter is enough if patient has low saturation, tachycardia. If you are good enough to read the ECG, get the ECG done. ECG shows deep S wave in lead 1, deep Q wave in lead 3, S1, S2, S3, deep S wave in chest leads like V1 to V3 with sinus tachycardia. These are the diagnostic features of pulmonary embolism. You don't require pulmonary angiogram immediately unless you have referred patient is in tertiary centers where the angiography facility is available. I'll show you the one of pulmonary angiogram of patient. See, this is right lung, this is right main pulmonary artery, this is upper trunk of pulmonary artery, this is lower trunk. The dye is injected into right pulmonary artery. See, this upper area is so well perfused, whereas lower area is ischemic. You hardly can see the pulmonary branches here because lower trunk is thrombosed with, so the lower lung has infarcted. This is called as pulmonary embolism. This is potentially life-threatening. If not treated immediately, patient can die. Friends, you'll lose patient within couple of minutes. Next life-threatening situation is thoracic aortic aneurysm. Dear friends, what is thoracic aortic aneurysm? Aneurysm is an irreversible dilatation of thoracic aorta. Here, pain may impinge on this aneurysm may impinge on the neighboring structures and leads to pain. The pain may be deep, persistent chest pain, dysphagia, hoarseness of voice, or cough. See, friends, this is the irreversible dilatation of aorta. This is called as aneurysm. Here, this is the thoracic aorta, descending aorta is dilated. Here, abdominal aorta is dilated. Next life-threatening condition is aortic dissection. What is aortic dissection? Friends, there is a disruption in inner layer, the intimal layer of aorta, that leads to dissection. There is a passage of blood into the layers of aorta. This is very dangerous and life-threatening condition. This condition cannot be diagnosed at OPD level. It requires MR angiogram or thoracic angiogram. It can be diagnosed only in tertiary centers, my friends. Here you can have a high index of suspicion. If your ECG is normal, patient suffering from pain, tachycardia, high blood pressure and irregular or unequal peripheral pulsation, you must think of aortic dissection. The pain may be very severe in center of the chest, radiating to the back, a sharp ripping quality, not affected by changes in position, may be associated with weak or absent peripheral pulsations. Next condition is the mediastinal emphysema. Dear friends, what is mediastinal emphysema? Emphysema is an abnormal collection of air in the mediastinum, that is called as mediastinal emphysema. I'll show you the X-ray of one of my patient who had mediastinal emphysema due to esophageal rupture. He had repeated constant retching, vomiting that led to esophageal rupture and mediastinal emphysema. See, this is the mediastinum. See, there is a thin strip of air, this black strip of air in the mediastinum. This is called as emphysema, mediastinal emphysema. My dear friends, it requires urgent intervention. If you do not intervene urgently, if you do not tap this air out of the mediastinum, this causes cardiovascular collapse and patient may die immediately. How to diagnose this? What are the clinical features of mediastinal emphysema? Pain may be sharp here, intense, localized to substernal region, often associated with audible creps. What is mediastinal creps? I'll tell you, friends. It is a paper-like creps. You know, if you fold the paper, how it makes noise, similar kind of creps you get on auscultation. This is the classical feature of emphysema. Next condition is acute pericarditis. What is acute pericarditis? Inflammation of pericardium. Dear friends, as the visceral organs are covered by the membrane called as peritoneum, pleura, so heart is covered by membrane called as pericardium. See, this is the heart inside the pericardium. This is the membrane covered entire heart. It has two layers, friends, visceral pericardium and parietal pericardium. The space between this pericardium is pericardial space. This visceral pericardium is inflamed here. It could be due to infection or malignancies or infarction itself. Myocardial infarction itself leads to inflamed pericardium. This leads to abnormal collection of fluid in the pericardial cavity that compresses the myocardium or heart entirely. That leads to cardiovascular collapse. Here, how will you diagnose this in clinical settings? The pain usually steady, crushing, substernal, often has pleuritic component aggravated by cough, deep inspiration, and worse in supine position and relieved by sitting upright. And on examination, pericardial friction rub often audible. Next condition is pleurisy. What is pleurisy? My dear friends, like heart, lungs are also covered by a thin membrane called as pleura. There are two membranes. One is parietal pleura, another is visceral pleura. The visceral pleura is inflamed due to infection of the lung, or traumatic injury to the lung, or it may be malignant tumor that leads to pleural effusion, pneumothorax, Usually unilateral, the pain may be knife-like, superficial, aggravated by cough and respiration. I'll show you the X-ray here. See, this is right lower lobe infection that had led to huge pleural effusion. I'll show you the another this patient, a COPD patient who had a bullous rupture and developed pneumothorax. See this, the abnormal air collection between visceral pleura and parietal pleura that has compressed the entire right lung and collapsed it. The trachea is shifted to the left side, mediastinum slightly shifted to the left side. Here you can diagnose it with a stethoscope, my dear friends. On the affected side, air entry is almost diminished or absent. You don't require hi-fi investigations like CT scan and everything. Even simple stetho is enough to diagnose the pneumothorax. If you hear the respiratory sounds carefully, the affected side is devoid of breath sounds. The air entry is diminished or totally absent. If the pneumothorax is large enough, then the right side affected side may be totally absent air breathing sounds. Here, this is again, it is a potentially life-threatening condition, my friends. Medically, you cannot treat it. It is a surgical condition. Patient needs urgent intervention. You must put the intercostal drainage and drain the entire this abnormal air collected in the pleura. My dear friends, life-threatening causes are over. Now, other non-cardiac or non-cardiopulmonary causes that cause chest pain we discuss now. My dear friends, we begin with the neck. Neck. What is the first cause to cause cervical spondylosis or disc prolapse? Is the first thing to cause chest pain. Here, the radiating radiculopathy can leads to similar like anginal pain. Pain may be chest, right or left side, radiating to the arms. But the differentiating feature here is affected side, arm, even fingers can feel numbness or weakness sometimes if it is so severe. That is a differentiating feature. Here, simple cervical X-ray can enough to diagnose. Here, you don't need any sophisticated investigations. It is not life-threatening also. Next, a rib fracture. Rib fracture is almost, you get a traumatic history enough to diagnose. A blunt trauma can cause rib fractures. See here, there are multiple rib fractures. If the fractures are multiple ribs involved, then it is again life-threatening condition. Friends, it requires urgent intervention. Do not keep that patient. If a single rib is fractured, you don't have to worry. Just strapping on the affected side of the chest is enough. It takes care of. Here, the pain may be localized to the affected rib, and on auscultation you get cracking sound. That is a classical feature of fractured rib. Next cause, bone metastatic lesions. My friends, here you don't require to investigate further because already you get past history of malignancies, either it is in the breast or lungs or abdominal or some other malignant lesions. Secondary to that has progressed to bone metastatic lesions. That leads to pain. Here you can simple X-ray, you can get it the simple X-ray done. That is enough to diagnose the pain. Here, simple analgesics are enough to treat the patient. Nothing can be done much medically and surgically if metastatic lesions are developed. Next is costochondritis. This is a condition, it is a benign condition, friends. Inflammation of the costochondrial junction, that is called as costochondritis. It usually occurs in young females, young boys, and especially in psychosomatic diseases. It is a benign condition. Simply you can treat with the simple analgesics. It will subside. Pleurisy we have already discussed. Pericarditis we have already discussed. Next, gastric causes we discuss. Gastroesophageal reflux disease. My dear friends, a patient is suffering from hiatus hernia that leads to reflux of the gastric content, especially acid. Acid is corrosive in nature that inflames the esophageal mucosa that leads to pain. And if patient has a epigastric pain, you must suspect peptic ulcer disease. Next is if patient has a left hypochondriac pain radiating to bad, severe in nature, associated with vomiting, you must have high index of suspicion of pancreatitis. If patient is alcoholic, then you must think of pancreatitis. Pancreatitis is an abdominal emergency, my friends. It will not kill immediately, but it definitely life-threatening condition. If not patient admitted and treated properly, patient can definitely die. So do not keep the acute pancreatitis patient in the OPD and do not try to treat it. Please send it to a higher centers for the further management. On the right hypochondriac region, if patient complains pain, tenderness, then think of cholecystitis. Here the differentiating feature is pain usually occurs with heavy meals, fatty meals, oily, spicy meals, and pain radiates to tip of right shoulder. That is the classical diagnostic feature of the cholecystitis, friends. It may be due to infection or acalculous cholecystitis or calculous cholecystitis. This is the classical feature of the cholecystitis. You can diagnose in the clinically. You can confirm with the USG abdomen, but it is not the life-threatening condition. Even you can treat in the OPD level if patient is stable. My dear friends, next condition is esophageal spasm. A patient, many times we may develop if we drink too much hot fluid or too cold fluid, we develop severe spasm of esophagus and that leads to pain. Here, if you give sublingual nitroglycerin, patients get immediate relief. That is a very misleading feature of esophageal spasm and coronary artery ischemia. Next is pneumonia, friends. Pneumonia is the inflammation of lung parenchyma. Either it is due to infection or malignancy or infection of lung. The feature is here typical. Patient may complain of pleuritic chest pain, especially inspiratory chest pain, cough with expectoration, hemoptysis, fever. If patient is maintaining oxygen saturation, you can treat this patient on the OPD basis. If patient is breathless, tachycardic, tachypneic, then patient needs hospitalization. Friends, don't keep such patients. They don't die immediately but die surely. Next cause is shingles. Shingles also called as herpes zoster. Friends, it is caused by herpes virus. It usually occurs one side of the body on the dermatoma of nerve root that causes tremendous pain, friends. If you do not remove the patient's cloth and see, you will not be able to diagnose. Unless you see the lesion, you will not be diagnosed. If you see the herpes simplex, herpes zoster lesions, clinically you diagnose it. You don't require any hi-fi investigations. You do not even require blood investigations, friends. You can treat it clinically and patient will be better after 15 days. And now I'll tell you the clinical features, how we can get benefited, how we can diagnose this on the basis of clinical features, symptoms and signs, likely etiology. The pain is localized, sharp, stabbing or persistent, dull pain reproduced by pressure over the painful area. It is likely costochondritis or chest wall pain. My friends, it is always non-life threatening. You don't have to worry about it. If patient complains pinpoint pain or tenderness on palpation, it is a localized pain, friends. You don't have to worry, and you don't ask for the hi-fi investigations. All you require is a clinical examination. That is enough. Sharp pain may be irregular in distribution, either right arm, left arm, exacerbated. It is exacerbated by the neck pain, neck movement, back movements. Then likely the cause of cervical or thoracic spine disease with nerve root compression, my friends. I'll tell you the classical feature of cervical spondylosis. If you get tenderness on the supraspinatus, the superior border of the trapezius muscle, that is the classical feature of cervical spondylosis. You don't require any investigation here. Clinically you can diagnose just a tenderness on the superior border of a trapezius muscle. That is enough. Pain may be associated with dysphagia or gastric regurgitation, may be worsened by aspirin, alcohol, ingestion or certain foods, or worse in supine position, often relieved by antacid. Then the etiological cause may be esophageal or gastric pain. Next, intolerance of fatty foods, right upper quadrant tenderness also present. The pain likely to be from biliary tree. It may be a calculus cholecystitis. Next, pain precipitated by exertion or emotional arousal. ECG during pain shows ST segment shifts. Pain relieved quickly within 5 minutes by sublingual nitroglycerin. That is highly suggestive of myocardial ischemia. Now I'll tell you the type of pain and consideration of diagnosis. Description of pain, background history, key physical findings and consideration of diagnosis, and confirmatory tests it requires. That is, pain oppressive, constrictive or squeezing, may radiate to arms or neck, back. The pain may be less severe, similar pain on exertion or past history of coronary risk factors. On examination, diaphoresis, that is sweating, pallor, heart sounds S4, gallop, common. You may not be able to diagnose in the clinically unless you have a high suspicion. This all features suggestive of acute coronary syndromes. Now, what is the diagnostic test in the OPD level? Serial ECG. Initial ECG may be normal, friends. If you suspect coronary artery disease, do not send the patient with first ECG normal. Ask the patient to wait for 1 or 2 hours and repeat the ECG. That may suggest myocardial ischemia or infarction. If you are have a facility to get the biomarkers, cardiac biomarkers done, get the cardiac biomarkers like troponin I, troponin test or CPKMB, then you may get some clue. Next, tearing or ripping pain may travel from anterior chest to mid-back. Patient clinical findings are hypertension or Marfan syndrome. Key physical findings: weak, asymmetric peripheral pulses, possible diastolic murmur of aortic insufficiency. My dear friends, think of aortic dissection. Here, the diagnostic test you require is X-ray chest, widened mediastinal silhouette that is classically suggestive of thoracic dissection. Or if you are nearby any CT scan center, you can ask for the CT chest. Next description of pain is crushing, sharp pleuritic pain relieved by sitting forward, recent upper respiratory tract infection or other conditions which predispose to pericarditis. Pericardial, on examination, pericardial friction rub. This suggestive of acute pericarditis. Here the again confirmatory diagnostic test ECG is sufficient at OPD level. ECG shows diffuse ST segment elevation in all leads, global ST segment elevation, that is suggestive of acute pericarditis. If you are nearby any hospital or a cardiologist, you can send him for the echocardiogram. Pericardial effusion may be often visualized in echocardiogram. Next type of pain, pleuritic, sharp, possibly accompanied by cough or hemoptysis. Recent surgery or other immobilization. On examination is patient tachypneic, possible pleural friction rub. Then think of pulmonary embolism. Here again it is difficult to diagnose in the OPD level. If we are quite intelligent enough to read the ECG can show deep S wave in lead 1, deep Q wave, but that is pathological Q wave in lead 3, deep S wave in chest leads V1 to V3 with tachycardia, that is suggestive of pulmonary embolism. And there is a dropping oxygen saturation, that is again augmenting your diagnosis. And final, the diagnostic test is here pulmonary angiogram. Next type of pain is very sharp, pleuritic, recent chest trauma or a history of chronic obstructive lung disease. On examination, patient is tachypneic, decreased breath sounds on the affected side or hyporesonance over the affected lung field. Then think of acute pneumothorax, that is abnormal collection of air in the pleural cavity due to ruptured lung parenchyma. Then clinically you can diagnose this condition very easily if you examine clearly. You can, even your single stethoscope is enough to diagnose this condition. At the affected side, air entry is diminished or totally absent. That is the classical finding of acute pneumothorax. You can ask for the X-ray chest nearby your setup. You get the abnormal air collection in the affected side of the pleural cavity with trachea shifted to the opposite side of the lesion and mediastinum shifted to the opposite side with partial or full lung collapse of the affected side. Here you cannot treat on your OPD basis. My dear friends, this patient require urgent intercostal drainage and drain the trapped air in the pleural cavity. Next type of pain is intense substernal and epigastric, accompanied by vomiting plus or absence of hematemesis, recent recurrent vomiting or retching that gives a high-index suspicion of esophageal rupture. On examination, you may find subcutaneous emphysema, audible creps adjacent to the sternum. Think of rupture of esophagus. Here the diagnostic tests are X-ray chest shows pneumomediastinum, as previously I had shown X-ray chest of one of my patient. Then esophageal endoscopy is diagnostic here to locate the site of esophageal tear. This patient requires hospitalization and if required intervention. Please do not keep such patients. Thank you for watching and with patience.